Thank you everyone for joining us today. My name is Genevieve Frazier with Rogers Behavioral Health, and joining me today is Dr. Camila Albuquerque and Dr. Adrianne McCullars to talk about mood disorders and personality disorders. We do have a couple of housekeeping elements before we begin. The webinar is scheduled for 90 minutes, and in order to receive the full CE credits, you must be logged on for the entirety of the presentation. We will track attendance by Zoom's login and log out records. A PDF of the PowerPoints as well as supporting references and documents will be sent out via a link after the program in an email to your personal dashboard on ce-go.com. In addition, we will have a recording of the webinar available to you on Rogers' YouTube channel within the next 24 to 48 hours. Following the presentation, we will conduct a question and answer session. If you'd like to ask one of our speakers a question, please utilize the Q&A button at the bottom of your Zoom taskbar. And at the end, we will compile those questions and complete the Q&A. Finally, we have enabled closed captioning for your program. I'll now turn it over to our presenters.
Thank you, Genevieve, for that great introduction. Hi to everybody. Welcome. Thank you so much for taking the 70 minutes out of your day to hear Dr. Albuquerque and myself talk about personality and mood disorders. This is just our disclosure slide. I just want to briefly look over some learning objectives. I know everyone has been made aware of what those are. Hopefully, if Dr. A and I are able to do our job today, you will walk away with these three pieces of knowledge from today's presentation. So hopefully that is what will happen, and we will do our best to make sure that it does. So overall, what we will be covering, we're going to level set a little bit. The first part of the presentation, maybe it's stuff that you already have heard or know. Maybe it's new to you, or maybe it just reinforces the knowledge and learning that you already have. So that's what the first part is going to be. The middle section is really talking about the connection of that PD and mood disorder. That's why we're all here. We want to hear more and learn more about what that is, what that looks like. And then the last part of today, we're going to focus in on treatment. We're going to talk about some CBT interventions. Dr. A is going to speak to some psychopharm interventions. And we're also going to talk a little bit about some treatment challenges. And then this last section, we will also discuss a case study and just kind of walk through some of the different components within that case with regard to treatment and application of that treatment. So since you all will be spending a little bit over of an hour with us today, we wanted to take some time and allow you and share some of our personal identities and professional identities with you. So I am Dr. Adrianne McCullars. I am the Executive Director for Clinical Services for the Service Area C region of Rogers Behavioral Health. I have a PhD. I'm a licensed clinical psychologist. I identify with the pronouns she, her, hers. I am biracial, female, able-bodied, and I am a mother and a wife. Dr. A, would you like to introduce yourself?
Of course. So I'm a psychiatrist. I work primarily here at Rogers Miami with the adult population. Pronouns that I identify with she, her, hers. I'm from Brazil, originally, so Latino. I'm also a mother and a wife.
Awesome. Thank you so much. Let's go ahead and get started. So we're going to start today by talking about just broad-based what are mood disorders. So mood is defined as that pervasive and sustained feeling that you have internally, and it's going to impact pretty much all aspects of that person's behavior in that outside world, whether that is family, school, work, etc. So it is going to be pretty pervasive in the way that it impacts that individual. They will also notice kind of a really significant disruption in their emotions. So they may go from severe lows, which would be that depression piece, severe highs, which would be that hypomania or that manic piece. If you're looking in the DSM-5, mood disorders have kind of a broad category as either bipolar disorders or depressive disorders. But within that, the two most common ones are going to be that major depressive disorder as well as the bipolar disorder. When talking about major depressive disorder, the ranges of prevalence kind of vary between adults, between that 16% to 25%. So it's kind of a wide range of individuals who do experience major depressive disorder within their lifetime. And in 2020, they surveyed about 20 million US adults, and about 8.4% of those reporting having had at least one major depressive episode within that year. So that's not stating that they were necessarily diagnosed with major depressive disorder, but they did report having an episode, 8.4% of those individuals. When you're looking at the specific symptoms of MDD, you're going to need to have at least 5 or more symptoms present during that 2-week period of time. And during that time, you need to have a distinct change from your previous functioning to the current level of functioning. And then on top of that, you need to have that significant impairment or distress in, social life, academic life, vocational life, etc. And then one of the 2 symptoms listed below need to be present for the diagnosis. So either having that depressed mood most of the day, nearly every day, or that loss of interest or pleasure. The depressed mood piece will look differently if we're looking at children and adolescents. The presentation today is going to be primarily focused, or not primarily, is focused more towards adults. So just know that some of these symptoms are going to express differently when you're dealing with that child or that adolescent population. And these are some additional symptoms that are listed that you may see when working with your patients, that change in weight, insomnia, or just sleep troubles in general, any fatigue, loss of energy, not really wanting to do things they used to do, not wanting to do anything new that maybe they've wanted to do in the past, a lot of worthlessness, that difficulty concentrating, etc. And then also you might see that component of those thoughts of death or the suicidal ideation. So when we're looking at this, we're looking at ages 18 and up with regard to this study that was done, or the survey that was done in 2022. When you're looking at those that were diagnosed with a major depressive episode in the past year, so the age group that was impacted the most was that age range 18 to 25. So on the left-hand side, that first green bar, that grouping of bars there is looking at those who reported having had a major depressive episode. So 20.1 of those was the highest group, and that was that age range of 18 to 25. And then if you look at the right-hand grouping of columns, those are individuals who were pulled out of that subset of major depressive episode that they had in the past year. They also reporting having had significant impairment in their functioning. So of that grouping, 14.7% reported having a significant impact to their functioning as a result of their major depressive episode. And again, it was that 18 to 25 range. And then right under that, that 26 to 49-year-old range for both of those subsets. So if we see MDD, that's kind of the age range that we're looking at for those that may be the most impacted. And when looking specifically at who is impacted in terms of depression, depression is about 50% more common among women as compared to men. And women's overall lifetime prevalence for major depressive disorder is about 21%, and men's being 12%. There's a lot of different explanations as to why, but one of the biggest ones is that women tend to have different social experiences, different biological experiences that cause them to experience depression differently than men do, hence the difference in the percentages based on what the different components that happen in a woman versus a man's life is what contributes to the difference in that percentage. And then when looking at those adults who reported experiencing a major depressive episode, you'll see that those who identified as multiracial were 16.4% of those reported having a major depressive episode. Let me just get my words together. And then 9.2% identified as white, 8.8 Hispanic, and 7.6 American Indian, Black adult 6.6, and Asian adult 6.3. So you'll see that those who identified as multiracial, as well as those identifying as white, reported a higher percentage of major depressive episodes as compared to other groups. I just want to check in, Dr. A, did you have anything to add about major depression as we go on?
I'll jump in. Anything.
Okay. That's kind of how we're going to do it. So if we have something to say, we're just going to hop in a little bit informal in this way. So with bipolar disorder, moving on to that mood disorder, about 2.8% of US adults report having experienced bipolar disorder in the past year. There's 3 different types. You have bipolar 1, you have bipolar 2, and you have cyclothymic disorder. It has been also estimated that about 4.4% of US adults do experience bipolar disorder at some point in their lifetime. And it's usually diagnosed during late adolescence or in that early adulthood period. which is interesting if you think back to some of those graphs with regards to major depressive disorder. That was also a range of when most people, that age range, reported higher levels of having experienced that in the past. With bipolar disorder, it causes those unusual shifts in that mood with regards to energy, activity level, concentration. And bipolar disorder, for every single person, it's going to look a little bit different in its presentation, but it is something that is going to require lifelong treatment to help it stay managed for that individual to be able to function effectively. And with bipolar disorder, there are specific criteria in order for it to be diagnosed. So you need to have manic episodes that last for at least 7 days, nearly every day for most of the day, or those manic episodes have been so severe that you needed medical care, or the depressive episodes are occurring concurrently, and those tend to last about 2 weeks. And then if we shift to bipolar 2, that's really that pattern of depressive episodes and the hypomanic episodes. So hypomanic episodes are less severe than manic episodes in bipolar disorder. And then hopping to cyclothymic disorder, this is that recurring hypomanic depressive symptoms. They're not really intense enough and they don't last as long to qualify for hypomania or a depressive episode, but they're still present. And so just to kind of clarify, manic episode symptoms versus depressive episode symptoms, obviously mania is going to be feeling very up, elated, feeling high, intense irritability, decreased need for sleep, all of those things. And then a depressive episode is basically the exact opposite of that. These individuals are going to feel very down, sad, maybe even having some anxiety, and just not able to do your everyday simple things that one might be able to do when not experiencing a depressive episode. So I just wanted to make sure we clarified both of those things. So they are basically the polar opposite of each other. When looking at diversity when it comes to mood disorders, so the past year prevalence was similar for males as it was for females. They were not drastically different, but the highest rates of mood disorders were found between that age group of 18 and 29, if you think back to that bar graph, with about 4.7% of those individuals being diagnosed with bipolar disorder. So within that 30 to 44 range, 3.5% were diagnosed with bipolar disorder, 45 to 59, 2.2, 16 older, 0.7. So you'll see within that 18, that late adolescent, early adulthood age range is really when we see a lot of the mood disorders start to show up. You will see that later in the presentation, this is something similar to that of personality disorders. And when they also start to emerge, it's that late adolescence, early adulthood range as well. So speaking of personality, let's go into that. So what is personality? We've probably all heard this before. We've probably all talked about personalities and are knowledgeable of them. Again, some of this may just be a review for you all, but I think it's always good for us to level set as we go into talking about the connection between these two. So personality is the way we all think and feel and behave, the way we see the world. Obviously, our personality is influenced by the different experiences we have, the different environments we've grown up in, and even genetic characteristics that we come into the world with. And personality usually stays pretty stable over time. The statement in attachment theory is from cradle to the grave. Your personality sticks just like your attachment style is going to stick. And so what is a personality disorder? So when someone is diagnosed with a personality disorder, the way they think, the way they feel, the way they act is usually deviating pretty significantly from the expectations of the culture or the environment from which they are in. And this deviation causes a lot of distress for that person. And it also significantly impacts their functioning. And it tends to repeat itself over and over and over again over the course of time. So the pattern that they engage in with that experience and then their behaviors, you're usually going to see this late adolescence, early adulthood. So as you can see, a lot of similar timelines here with the development and the evolution of personality disorder, as we just spoke about when it comes to mood disorders. And this starts to impacts their functioning around that time as well. And unfortunately, personalities they're long-standing. They're going to be with that person for the longevity of their lifetime. They're usually pretty pervasive, meaning that they're going to impact them in many different areas of life, not just one or two. It's going to impact them in multiple areas of their life. They seem to be pretty inflexible with their thinking patterns. So a lot of rigidity, a lot of black or white thinking, a lot of extremes, all or nothing type of things. And it is a persistent pattern of behavior. So personality disorders tend to affect at least two of these areas. So the way the individual thinks about themselves or the way the individual thinks about others. It can impact the way that they respond emotionally to certain situations or triggers or environments. It can impact the way they relate to other people, and it can impact the way that they control their own behavior. And within the DSM-5, there are 10 specific types of personality disorders that they've laid out within that cluster, A, B, and C. So this is the category of personality disorders. You've got A, that's your odd and eccentric personality disorders. You've got B, dramatic emotional. You've got C, anxious and fearful. And within those are the different specifics that exist. So we're just going to go into a quick review of what those specific personality disorders are. Just to make sure that we're all on the same page with regards to our knowledge and understanding of all of this. So with regard to cluster A, that's your paranoid, your schizoid, your schizotypal personality disorders. And then within cluster B, you have your antisocial, your borderline personality disorder, your histrionic personality disorder, and your narcissistic personality disorder. This cluster, as you'll see as we move on, is more closely linked with mood disorders as compared to some of the other clusters. And then you have cluster C, the avoidant personality disorder, the dependent personality disorder, and then you have the obsessive compulsive personality disorder. So that's cluster A, B, and C in a nutshell. And within them, there's 3 or 4 different types of personality disorders that are categorized. But keeping in mind that that cluster B is really where we're going to start focusing on towards the middle of the presentation, once we start to really talk about the connection between the two. So with regard to diversity considerations when it comes to personality, about 30% of psychiatric outpatient patients in the US are diagnosed with at least one personality disorder, with the most frequent one being borderline personality disorder. Also, the adult lifetime prevalence of BPD is about 6%, which equates to about 14 million individuals. There have not been any differences found between the rates of BPD among men and women. So this little fact may be different than what you may have thought originally. I know originally the research kind of highlighted that BPD was way more prevalent among women than it was men. And recent research has highlighted that it's actually way more equal than we suspected. But previously, women were seeking services more often than men for this. So the numbers were a little bit skewed. And then in non-clinical community samples, the rate of PD has ranged between 4 to 10%. And then also when you're just looking at the prevalence of PDs in general, not taking borderline into account, there's also been studies that have shown that range is between 9 to about 16%. So again, it's not a tiny amount, but it is a nice chunk of individuals who are diagnosed and might be struggling with a component of PD that maybe as a provider, we need to really take into account when we're treating that individual, especially if it's coming along with a possible co-occurring mood disorder. So speaking to some of the diversity considerations among personality, the Black and Asian population has been found to have a statistically significant lower prevalence of that PD as compared to white populations. So now that we've kind of level set, we've reviewed everything. For some of you, it could have been a review. For some of you, it could have been new information. We're going to move on to talk about kind of the bread and butter of this presentation. Like, what is the connection between the two? What is the connection between personality? What is the connection between mood disorders? So hopefully in the next few slides that we'll be able to highlight this for you all and make that a little bit more clear. So when you're looking at this graph, you can see that a large majority of people with personality disorders also had one or more co-occurring mental health disorder. So on the left-hand side of this column, you'll see that is listing any personality disorder and what percentage of those individuals struggled with any anxiety disorder, any mood disorder, impulse control disorder, substance use disorder. And you will see that many of them had one or more co-occurring mental health disorders, with anxiety and mood actually being the most prevalent among any personality disorder as compared to the others. And then if you look on the right-hand column, they specifically pulled out borderline personality disorder from this study and looked at it by itself. And within those who are diagnosed and are experiencing borderline personality disorder, 60.5% of them also had a co-occurring anxiety disorder, and 34.3% of them also had a co-occurring mood disorder. And you will notice that borderline specifically, a thing that is different as compared to the any personality disorder category, is that they were at 24.1% of those individuals who also had a co-occurring mood disorder. But then when you look in the BPD category, 34.3% of those also had a co-occurring mood disorder. So that percentage went up almost 10% in those who were also diagnosed with BPD. And individuals with BPD tend to have higher rates of comorbidity with mental health disorders, particularly anxiety and mood. And I think that's the reason we're doing this presentation, to really highlight that co-occurrence and to show that they're not necessarily struggling with BPD by itself. Obviously, that is what's going on, but there are some underlying things also going on, whether that's an anxiety disorder, whether that's a mood disorder, and a host of other things that could also be co-occurring that we as providers need to be aware of as we're building our treatment plans and as we're putting together that formulation as to how we're going to work with each and every patient that we see. So when you look at the prevalence of personality disorders within that mood disorders component, that avoidant, borderline, dependent personality disorder were found to be the ones that co-occurred most frequently with mood. And the mood disorder that was found to be the most often co-occurring was depressive disorder. So cluster A was the least common PDs that co-occurred with MDD, and then clusters B and C were the PDs where that MDD co-occurred the most, where they found that co-occurrence most often. And then when you look at studies that are looking at the difference between mood disorders co-occurring with PD, the prevalence of major depressive disorder within those studies exceeded bipolar disorder as much as 45-1. So even when looking at the different mood disorders that tend to be linked or maybe occurring with personality, bipolar disorder was really not as prevalent as that major depressive disorder. Hence, again, the focus of this presentation, right? Really focusing in on that connection between the two. I think with borderline personality disorder, you can see a lot of symptoms that are coming out that could be very confusing or really hard to identify the specific root cause or what's going on. And just having this knowledge and information that this is the one that most often is occurring within PDs. It's just good knowledge to have as we're thinking about treatment planning or case conceptualization, et cetera. And then the prevalence rates of PDs in patients with MDD have varied. I mean, they range between 20 to 50%, but again, still on the higher end of that percentage. Now, when you look at borderline personality disorder and the prevalence of co-occurring disorders, these are the most common ones that are found within that co-occurrence between those two, with, again, major depressive disorder being at the top. So 60% of those who were diagnosed with BPD, 60% of those individuals were also diagnosed with co-occurring major depressive disorder. And so looking down underneath that, we have substance use 35, eating disorders, bipolar, antisocial, narcissistic, and then self-injury. So self-injury is more than likely often a factor with somebody with BPD as well. So moving into what is borderline personality disorder. Again, this could be a review for some of you. For others, it could be, additional or new information. But just so we can all level set again, Borderline personality disorder typically tends to occur in the context of relationships. These individuals are usually going to start expressing symptoms around adolescence or early adulthood. About 5.9% of adults at some point in their, that says lift, but it should say life. It will impact them about 5.9% of the time in their life. And BPD affects about 50% more people than Alzheimer's disease, and nearly as many as schizophrenia and bipolar disorder combined. So borderline personality disorder is something that is happening, and we're definitely seeing it in our patients. But the next step is, are we catching it? Are we treating it appropriately? What can we do to make sure that we are addressing it? And about 20% of patients who are admitted to psychiatric hospitals also have borderline personality disorder, and it affects about 10% of those in outpatients. So what is that symptomology? What does it look like? I mean, BPD is it's just a pervasive pattern of instability. And what are some of the symptoms that we might see within our patients who may be experiencing borderline personality disorder? Significant fear of abandonment, really unstable changing relationships, unstable self-image, maybe self-damaging behaviors, drinking excessively, doing risky things, suicidal behavior, self-injury, pretty significant, random, varied mood swings, a lot of worthlessness, a lot of guilt, a lot of sadness. Some experience very intense anger or aggressive reactions. And maybe even a little stress-related paranoia or that loss of contact with reality. I came across, when putting together this presentation, this mnemonic, and the word is impulsive. So I thought this was maybe helpful to share as we continue to go on and try to remember the symptoms when we're trying to assess our patients for BPD. So impulsive, I stands for impulsiveness, and it needs to be in two potentially damaging areas. And then M, mood, that shift in that mood. P, is there any paranoia? Is there any dissociation under stress? U, is that unstable self-image? L, intense labile relationships. S, suicidal gestures. I, inappropriate anger. V, vulnerability to abandonment. And then E, that emptiness, or just those chronic feelings of emptiness or being alone. So I thought that was just a helpful mnemonic to remember that symptomology, impulsive. Well, let's look at some diversity considerations when it comes to PDs and BPD specifically. So the lifetime prevalence of major depressive disorder within those who were diagnosed with BPD was 83%. So of those who have BPD, 83% of those also had co-occurring major depressive disorder. Now, the prevalence of those who have major depressive disorder as well as BPD was only 19%. So it is pretty significant that a majority, pretty close to 100% of those with BPD also experience major depressive disorder. Women with BPD are more likely going to have that co-occurring MDD, that anxiety, that substance use, or the eating concern. Men with BPD are more likely going to have substance use or that antisocial personality disorder component co-occurring with their BPD. You also have lower SES being more associated with borderline personality disorder. And then race and ethnicity, there's no significant relationship to BPD that was found, but it's been particularly difficult in the literature to determine what those racial or ethnic group differences are with borderline personality disorder. So there were a few studies that I did found that had some sense of what some of those differences may look like among a few groups, but the research is really lacking in some of that. And so hopefully that will be able to find some better data for the racial and ethnic differences. But in one of those studies, they had a sample of 554. They found that higher rates of borderline personality disorder were found in that Hispanic group as compared to that white and the African American groups. And then in another study, they found higher rates that were found in the white group as compared to the Black group. And another, as compared to the white group that they had, the Hispanic group were more likely to endorse 3 of the 9 criteria. So it's kind of all over the place with regard to the group differences, but that just kind of provides a small little snapshot as to what some of them may be. All right. Well, what do we do about it? So we know that mood disorders co-occur with personality, and we know that among those, borderline personality disorder and MDD have a really, really strong connection. We also know that both of these things tend to start to develop or start to emerge, or symptoms start to come out between that late adolescence, early adulthood time period. So I would say that 18 to 25 year age range. So what do we do about it? What treatments are out there with regard to depressive disorders? What treatments are out there with regard to borderline personality? And what do we do in practice? So hopefully this next section is able to highlight some of that for you all. So with regard to CBT interventions or cognitive behavioral interventions, when looking at MDD in comparison to BPD, so the APA highlights a lot of cognitive behavior, or a lot of interventions that are labeled as those that can be effective for MDD. You have a whole list. When you look at borderline personality disorder, it is going to be that dialectical behavioral therapy as the gold standard of treatment for BPD. And then, when you're dealing with MDD, there's a whole list of those of which to try. But then if you're dealing with BPD, it's DBT, right? So which one do I treat? When I have a person who has both MDD and then BPD in front of me, like, what do I do? What do I treat first? Where do I start? Well, if that is a question you've asked yourself before, hopefully this will help. I mean, the treatment of depression does not result in the remission of borderline personality disorder symptoms. So the research does show that pretty consistently. If you're only targeting the depression component with those individuals who also are diagnosed with borderline personality disorder, you're not going to see the BPD improving. And you may not even see the depression improving. So when you're treating someone who has BPD and co-occurring mood, effective treatment of that BPD, if you're focusing in on those BPD symptoms specifically, that has been shown to result in the remission of the depression. So there was one study that did show that major depressive disorder is not a significant predictor of outcome for BPD, but BPD is a significant predictor of the outcome for MDD. All that saying, you have to target the BPD. You cannot just focus on targeting and treating that MDD alone, because it will not be followed by improvement of the BPD. And we know that BPD is that primary. The depression exists almost as like that secondary symptom of the BPD. So if you're only treating that secondary symptom, that primary symptom BPD is not going to improve. And even if the depression does, in the short term, in the long term, it's going to keep coming back because it's very much tied to that primary diagnosis of that borderline personality disorder. So when looking at BPD and MDD, what are the similarities? What are the differences? So the similarities between the two, they're both going to have mood swings. But the difference is going to be the amount of time that they last, how frequently they occur, and just that time piece is going to be really important. And then feeling of emptiness and worthlessness, low self-esteem, high suicide risk, intense self-harming behaviors or really frequent self-harming behaviors, maybe even a past history of suicide attempts, low energy, disrupted sleep. Maybe they both experience guilt and shame. So that's a list of the similarities. I think at first glance, that can just look pretty much just like major depressive disorder or depression. But keep in mind that these are the symptoms that very much overlap and interplay with each other when you're treating somebody who has BPD as well as MDD. What are the differences? So with BPD, they're going to experience emotional disturbances, and those are going to tend to fluctuate a little bit more intensely and quickly as compared to someone with MDD, or even as compared to someone with another type of personality disorder. A key feature in BPD is also that really they have a difficult time maintaining stable relationships. That could be with partners, that could be with friends, that can also be with family. It's gonna emerge in multiple different areas of that category. And then that affect instability. So you're gonna see, those are some of the differences of BPD that you're not gonna necessarily see in MDD by itself. And then with MDD, you get more of that persistent, stable mood change. It's not going to drastically fluctuate. It's going to be a little bit more stable in its presentation and the course that it takes. So those are similarities among the two, and then the differences. Well, as you can probably imagine, when you have somebody who has BPD, but also co-occurring MDD, I'm sure some of you have already, had a case like this or attempted to treat a patient like this. These cases are very difficult. They're quite challenging. They are challenging from a diagnostic standpoint. They are also challenging from a treatment standpoint. Either way you slice it, they are challenging. So what are we looking at challenge-wise from a diagnostic perspective? So like I've already said, there is a lot of symptom overlap between the two, and it is actually pretty tricky to try to get an accurate diagnosis that then can help develop and lead our case conceptualization, our treatment formulation, and our treatment application. So that makes it really tricky from the diagnostic side. And then from the diagnostic side too, misdiagnosis, if we get it wrong or we don't hit the nail on the head, that could cause us to do all this treatment planning that really isn't like the best fit for the patient, which then kind of causes that delay in the patient receiving that appropriate care or the appropriate amount of treatment or type of treatment, whatever it may be. So there are some diagnostic challenges. And then there's the treatment challenges. Treating an individual who struggles with BPD and co-occurring MDD, it's a very complex treatment. You have to make sure that you are targeting the unique challenges of each disorder while also really paying attention to that interplay. The BPD it's just very unstable. It's very ever changing. Sometimes it might feel that you're kind of like playing that whack-a-mole game every time that they're in your office. It's something new, it's something different. And then add the MDD diagnosis on top of that, that's going to probably cause some significant impairment in their daily functioning. And also, these individuals are at higher risk for suicidal behaviors than those with either diagnosis alone. So you're managing risk on top of everything else that you're managing and trying to treat. So these have some significant challenges from a diagnostic and a treatment standpoint. Well, what can we do to help in treatment? Like, what can we do to better our treatment plans, to better our understanding, to make treatment really fit that individual that may be struggling with both? So you have to be able to treat that depression in the context of the person with BPD. And that can be a significant challenge because we do know that BPD is that primary and the MDD is considered secondary to that BPD diagnosis. For BPD, DBT is the first line of treatment. So you really want to pull from DBT as much as possible. And you really, if you have somebody who's super risky or has, high level risk behaviors, or they're engaging in things like that, that needs to be your primary focus to make sure that that patient is able to be safe in your space, be safe in treatment, not only with you, but also outside of treatment, and then throughout the duration of treatment, plus some. And you really have to work on developing that appropriate therapeutic relationship. So again, one of the characteristics of BPD is that fear of vulnerability, fear of trust. So it's key that you're able to build upon that and use that to your advantage as you're working with this client. So that way you're able to build trust, their trust in you, your trust in them, and their trust in treatment. The sessions need to be really structured, a game plan. What are we going to be focusing on today? What skill are we going to be learning today? How are we applying that? How are we going to practice it today? And then you want to make sure that every intervention you provide, which is kind of a way of using that therapeutic relationship, is providing a sense of safety for the patients. But again, you have to remember that BPD and MDD, although they co-occur, that MDD is viewed as secondary and very much tied to the BPD pathology. So you're going to have to pivot a little bit more than you would with somebody who just has MDD alone. So I'm going to turn it over to Dr. Albuquerque now. I think you all have heard my voice long enough. And she is going to talk to us a little bit about psychopharm interventions for this and some of future directions.
All right. So the focus here of my talk is going to be primarily on psychopharm, as well as other modalities of treatment for depression. And we're going to focus a little bit more on borderline personality disorder because that's the association we see the most here in the clinic. But before we jump into those interventions, like I mentioned, I always like to start with the basics. It's very, very hard to jump into the latest medication or to even more significant types of treatments, like we're going to talk later on, ketamine, TMS, ECT, without thinking and working with the basics, right? And when I talk about the basics, I really mean nutrition, hydration, sleep, the social interaction, socialization, exercise, and gut health, right? Lately, we've been seeing so much how much the gut health has a big impact on physical and mental health, right? So to focus completely on just what medication or what else to add, it leaves me missing so much of what I can do to help that patient. So the way I like to think and the way I always present to people that come to me for help is in a simple way of explaining medication treatment or a psychopharm way of thinking when treating depression, anxiety, which we saw is very comorbid with personality disorders. We have to think about the neurotransmitters involved in it, right? And the main one, in a simplistic way of putting it here, is serotonin. Of course, the other ones, dopamine, norepinephrine, glutamate, all of that is also involved. But if we just stop to think about serotonin here for a second, 90% or more of its production comes from the guts, not the brains, right? So the likelihood of me getting a patient to improve with the medication is if I focus on their gut health as well, not only the brain. And with that being said, I have to be thinking about the microbiome, the good bacteria, the good flora that grows in the gut, right? The way it works is we eat, our body absorbs the nutrient. When we talk about serotonin specifically, we're talking about an amino acid that it's present in most of the food. So if you're eating regularly, you're giving your body that nutrient that is going to be absorbed and transformed into serotonin, which will later on go up to your brain. So like baking a cake, you need those nutrients available for the production of serotonin, right? You need eggs, flour, milk, whatever it is to produce a cake. If you don't have those, the production is going to be low. And that's what I tell my patients when I'm working with them too. If we don't work with your nutrition, if I'm only prescribing you a medication, the way most of the medications that I'm prescribing in psychiatry, the way it works is they go at brain level and they block the reuptake of serotonin, whatever neurotransmitter they're working with, and they change some of the receptors. But really, if the production is low, the medications are going to be working with low production at brain level, right? So if I work down here with the gut, nutrition, water intake, the likelihood of these medications doing some kind of good is much higher, right? And these things are basics, but they're not easy to work with, right? It's hard to make those changes to your day-to-day, to work on eating more regularly, being more cautious about the amount of water that you're drinking, food choices, right? Or am I sleeping well? We know so much how sleep is important in regulating not only your physical health, but your mental health too. The importance of REM sleep on the last 4 hours of sleep. And are we working with those things to get the patients to feel better? Same way goes for exercise. So many works out there showing that when symptoms are mild to moderate, exercise is as significant as antidepressants or therapy, right? Imagine if you combined all three, which is why I really like working here in the clinic in Rogers, because we do this multidisciplinary approach. So the patient when it comes here, they are not only taking that medication, but they have intensive therapy and all these other modalities that we work with together with the medications. So we're talking about nutrition. We talked about sleep a little bit. We talked about gut health. Now we're going to talk about a little bit about medications. If we think about medication management for depression alone, right? We know that it's not like lots of patients respond to it. We see that a third of patients will respond to medications, and the more they try and the more they fail, the less likely it is that they're going to respond to another one. When you combine depression with borderline, the likelihood of response is even lower. So it gives us even more push to add more things on than just relying on the medication. There are tons of studies showing that patients with borderline, when they come to us, they're already taking 4 medications, 5 plus polypharmacy, right? Lots of as needed medication to treat every little thing that comes along. And then when we start to talk to the patients, we see that the basics are not being targeted, or patients are not being taught of what needs to be done, right? And the way I like to think of it is, think about a patient that has diabetes and come to you and you start giving metformin, insulin, but unless you teach your patient on how to switch their nutritional, if they don't stop eating chocolate all day long, no matter how much insulin you prescribe, it's unlikely that they're going to feel better. So I think the pieces with the treatment for depression and even personality pathologies, the behavior piece of it is very, very important. Okay, so if you could go to the next slide, Dr. McCullars, please. Yep. There are no medications that are FDA approved for the treatment of borderline personality disorder. And really, there are some guidelines that tells us that we're out of luck when really picking a medication to treat borderline personality disorder. We can think about it as to what symptoms are more present and what ways we could go in picking a class of medication. Back in 2001, that's when the guideline for APAs were brought up, and it talks about SSRIs being the first ones that we could offer, but later study shows that the response to them are not very good. The rest of side effects are lower, but response in terms of BPD symptoms are not the best. Cochrane data says the same thing. No specific medications is better than the other, and so did the other guideline there. So if we think about symptoms categories, right? If you think about affective dysregulation, like Dr. McCullars pointed out, or anger, impulsivity, cognitive perception disturbances, we can think about specific classes of medications. The 2 main classes that we saw the better response were mood stabilizers class of medications. If you think about the anti-epileptic medications, topiramate, Depakote, lamotrigine, those were more effective in the global response. However, the responses were not major, right? Because the trials are usually small samples. We see some response, but they're not like you're going to take it and you're going to feel better. You have to be relying on the other modalities of treatment too, like Dr. McCullars mentioned, DBT being the gold standard there. Some medications could be helpful if you think primarily on decreasing suicidality, like lithium, for example, or ketamine that we're going to talk later on. But for borderline personality disorder symptoms per se, we don't see that major change or improvement. Some. You could jump to the next slide.
Okay.
So there are studies coming out in showing the benefits of non-invasive brain stimulation for borderline personality disorder. Of course, we do have already FDA approval of TMS, ketamine infusion, ECT for depression only, but here we're talking about more of a comorbid case and potentially the benefits when we think about borderline personality disorder. Some studies showing some benefits of transcranial magnetic stimulation, as well as direct current stimulation, which is electricity to the scalp, and we try to stimulate some areas of the brain that could potentially be helpful in treating borderline personality disorder. These studies are very sparse. The samples are small, and it varies a lot, the symptoms that they're treating, and the results are very inconsistent. Like, for example, out of 4 studies with DCS, with direct current stimulation, 2 will show some improvement, 2 will show no improvement when you compare sham. So it's very hard to say, go and do that, right? It's limited the amount of evidence. When we see though, the patients that has depression as well as BPD, TMS or ketamine or these other types of treatment will help the depression in itself. But like Dr. McCullars pointed out, and it's very important to know, is that unless you treat the BPD as well, that depression will continue to come up later on. It's not going to be a long-lasting kind of effect. I think I have 1 slide on ketamine, I'm hoping.
I think the next one is our case study.
Okay, so let me talk a little bit about ketamine here, because there were studies coming on last year. The first one published in January and the follow-up in May about ketamine infusions for treatment of borderline personality disorder. The first one was just one infusion of ketamine, and they were looking really into treatment for borderline personality disorder. And what they saw was that there were no significant changes in depression or suicidality compared to midazolam, which was the control group, but some improvement in social functioning status, which related to work, family, marital relationships there. And they saw that the ketamine group tolerated the medication very well, which gives us space for more studies to come along. And the question that they raised was that, what if we do multiple infusions, like we have benefits for depression? What if that's the case for borderline 2? So a second study came up in May when they did 4 infusions in 2 weeks. And again, they saw improvements in the depression piece of things, but not in the core symptoms of BPD. So we have to have a little more hope that more studies will come along and help us with those things. But again, I think we cannot lose focus of the basics and helping them with those changes in behaviors, with which long-term can be maintained and likely come with a lot of positive changes.
Awesome. Sounds like the focus of behavioral change still stands, even with the addition of medication too, which is kind of the whole thing about Rogers. That's what we do, focus on behavioral therapy.
100%. Yes.
Well, that moves us into our case study. Thank you so much, Dr. A, for that. This case example, we're going to call this individual Mary. This type of a case is something that we see pretty frequently at Rogers. We typically see this type of a case within our depression recovery, which also sees a lot of mood disorder as well as personality disorder within that program. So let's just walk through this. So the addressing format on the left-hand side, this is a framework that's going to help us facilitate the recognition and the understanding and the complexities of this individual's identity. So this is a 22-year-old white cisgender single unmarried female who's a recent college graduate, presented to treatment due to a history of repeated self-injurious behaviors, specifically cutting, feelings of emptiness and worthlessness, having a lack of interest in activities, experiencing some aggressive behavior toward friends and family, weight gain due to binge eating, some depressed mood, extreme fatigue, sleep disturbance, specifically insomnia, so not being able to fall asleep or stay asleep. She also reported that all of these symptoms started within the past couple of years, and also having difficulty controlling her anger, intense emotional fluctuations. Also shared that family and friend relationships were very strained, and did report having failed multiple romantic relationships. She reported feeling insecure, fearful of rejection, feelings of loneliness and emptiness, indicated that she does have that daily passive SI. She was working part-time, but has been finding it harder to manage her heavy workload, always feeling behind, and is fearful of being fired due to not meeting expectations. So within this, I mean, I think we can all say, I can see some flecks of BPD, I can see some flecks of MDD, I can even see some of anxiety almost within there. There's a lot going on with this case. This is a very complex case, but unfortunately, I think this is the type of case that a lot of us see and that we all get, because in my opinion, no case is very clear cut. There's always going to be intersectionalities and complexities because we're working with individuals. We're working with humans who all have different experiences and things going on that are going to impact different layers of their mental health functioning. So which diagnosis is it? We have all of these that are coming up for this individual, Mary. A lot of recent self-harm, aggression, emptiness, fear of rejection, but we have depressed mood, we have insomnia, and that's depression. We have emotional fluctuations. Well, that's personality. We have being fearful of rejection or feelings of loneliness. That could kind of be depression too. So which one is it? There's just a lot of complexities. That's why when I say it is, although it is a challenge diagnostically, it is very important diagnostically that we take our time to try to tease apart really what's going on so that we were really able to treat the whole person and not just a piece of what we think is going on, but really that whole entire individual. Because what I've said and what Dr. A also said is that symptoms for depression might remediate, but the BPD symptoms are still remaining. And inevitably over the course of time, because we know personality is kind of a stable trait, those symptoms of depression are more likely to resurface or reemerge, even if the individual is receiving treatment for depression. So what does this mean? So when you look at the depressive symptoms that this individual was experiencing, you look at the borderline personality disorder symptoms that they're experiencing, and then you look at that overlap, you really are going to need to focus on that core pathology of that BPD when you have somebody who is diagnosed with both. Because like I've said before, and I can't stress enough, there's so many studies that have shown that once that BPD is addressed and somewhat subsides or is just better managed or controlled, the depression will follow. Borderline personality disorder is not an effective disorder, and it should not be treated as one. You really need to treat BPD with the gold standard, which is DBT, and then kind of weave within it some of the other components that we know are really effective in treating depression as well, once you get to that point. But if we ignore the BPD or just hope that maybe that's going to get better if we treat something that feels a little bit more safe, then we're not really going to have a positive outcome. So let's talk about what that means. So how are we able to look at these symptoms and figure it out? Like what can I give my patients to screen for this? Like how can I tease these things apart a little bit better? How can I develop a better understanding of the symptomology so then I kind of know where to start? Because this is a lot. Like this is not an easy case to treat. It's very tricky. It's difficult. It takes a long time. And it really, the first step is just having that patient, developing that relationship and that trust, and then building upon that and developing your case formulation. When we're looking at that diagnostic piece, so for depression, this is a list of some of the screenings you can use. I did also put on here whether it's something that you would need to pay for to get, or if it was something that was like free to the public. So there are quite a few that are free out there, open source to the public, that you can download off the internet and start utilizing in your practice to help you tease apart some of the symptomologies. I know that some of these, we use at Rogers to help us also tease apart symptomology. And then there's also a list of screeners or, short things that help you tease apart personality specific to borderline or specific to personality. Like the SCID is specific to personality, not just borderline. And same thing with the PDI. But of all of these within borderline, so if you know that that is something that you are dealing with, that you have done your screenings, you kind of feel confident that this person is struggling both with borderline and also with depression, something that I have found extremely helpful is the FIAT. So this is also a free, open source to the public questionnaire. It is an interpersonal relationships questionnaire. It covers 5 domains of interpersonal functioning. I can't remember all 5, but conflict, interpersonal relationships, emotional response, all the kind of the key features that would really overlay nicely into some of the DBT skills. But I think what it can highlight, the most important thing with BPD, even if you figure out if it's BPD or even if you don't, what are the problematic behaviors that the individual is doing? And how can we tie skills or tie treatment to those problematic behaviors to help increase their level of functioning in the future? And the FIAT is a nice questionnaire to give your patients. It's fairly long. I believe it's about 5 pages, single space of questions going through each one of those domains, but it can really highlight for you the specific areas within those domains where the patient is struggling, allowing you to really hone in on your case formulation and being able to see, okay, well, it's not conflict that they're struggling with. It's more of that like interpersonal relationship piece. It's more of their like emotional expression. It's more about how they're being able to receive feedback and the way they're perceiving that feedback, which can obviously influence your patient in work, in social life, in school, in a lot of different areas with family. So using something like the FIAT to help you tease apart the different domains that that individual may be struggling with can be really useful and helpful. Borderline may be borderline in its title with 5 different patients, but the way it presents across those 5 different patients is different. You may have treated, if you've treated one person with BPD, you've treated one person with BPD, right? I mean, the way it expresses is so different across each and every single person, not only from a behavioral perspective, but from a psychopharm perspective. There's not going to be 2 patients that really look alike. So using these questionnaires to really nail down, I would say all the questionnaires listed under the BPD list up until the FIAT are more about like, do you have this or not? What PD do you have? Whereas the FIAT is really focused on what behaviors are you engaging in that are most tied to PD, but let's figure out what you're actually doing that's problematic. I don't care what you call it. It's more about what are the behaviors that are going on? How are they negatively impacting you? What can we do as clinicians when you're in front of us and in treatment to target those behaviors to help you function more effectively in the future? And then also pulling in some interventions for depression. Here at Rogers, we really focus on behavioral activation because it is very behavioral, looking at routine, enjoyable, and valued activities and helping weave those things back into this individual's life to slowly target that depression while we're really targeting those higher level BPD symptoms that are negatively impacting their day-to-day. So these are just some things that, are a lot of them are free that you could utilize to incorporate in your treatment plans with your patients that may be struggling with one or both of these things. So there are three things to keep in mind when you're managing somebody who may have BPD and you also may have major depressive disorder. Even though it is going to be challenging, like we spoke to before, there are diagnostic challenges, there are treatment challenges, but really trying to do a comprehensive assessment and a comprehensive screening to see if you're able to figure out from a symptom perspective what is going on. And then tailor your treatments. Use something like the Fiat to really help you hone in on those problematic behaviors and making sure that if you have a patient who is struggling with self-harm and suicidal ideation, but then you have another patient who's not, that patient who's struggling with those risky behaviors, you're going to have to focus there. You're going to have to help them with skill building and help them be able to maintain their safety both in and out of treatment. So that becomes like that primary focus first, and then you can move into other things. Whereas somebody else, maybe they're starting at a different place and you're able to really start targeting some of those more ineffective behaviors. And then the other thing that is really important when working with these cases, we've talked a lot about challenges, both in treatment, both psychopharm, and both in like diagnosis and assessment. This population is very tricky. It can also be very, very draining. So make sure that as a provider, you're engaging in appropriate self-care. You are doing things outside of work that are helping fill up your cup and is not just completely draining you at the end of every day. Because again, these cases are tricky and it can feel like that for some time until you really feel like you're gaining some momentum. So just make sure that you are engaging in appropriate self-care and that, you're taking care of yourself and also your colleagues. Dr. A, do you have anything else before we wrap it up?
Just
anything from your perspective? Yeah.
Yeah, I was just going to reinforce what you just said, because it's exactly that. You may treat 10 cases of comorbid BPD and MDD, but each case is going to be very different and each case is going to bring its own challenges, right? You have to stop and think about the things that we brought up here, the importance of background, cultural beliefs, like how does this patient express themselves? What is going to be the struggles of talking about emotions and symptoms? What are their support system, right? Is it talked about at the house? What is the environment? And unless you're open to learning and working with all of that, it's going to be very hard to really get that person to get to where they want to be, right? And it's a matter of, again, the same thing about each case being different, each patient improving each day based on what they're bringing rather than comparing with a different case that you had, right? And the final piece of important point here is that it's always very, very hard when these people come to us struggling a lot and we're trying very, very hard to help them, but there's just so much that we can do, right? We're here teaching, explaining, showing, but at the end of the day, we also have to allow the patient to have their time to be ready to work on themselves and be okay with it, and recognize that it's not always about you, because it can be, like you said, very draining and very distressing when we don't see the improvement that we wanted to see, right? So taking a step back and allowing the patient to have their time to be ready to work on themselves is also part of that.
Yeah, agreed. Well, thank you so much for everybody who came today. Appreciate you attending and taking time to hear our topic and learn more about this co-occurrence and hear about how we as providers can try to provide the most effective treatment possible.
Thank you so much, Dr. McCullars and Dr. Albuquerque. We do have time now for question and answer. So if you do have any follow-up questions, please use the Q&A button at the bottom of your screen to submit your questions. I am going to be grouping some of them together because we have some nice themed questions for you all. And then also, if we don't answer your question or you'd like to follow up with us, please feel free to send us an email after the webinar to webinars@rogersbh.org, and we can follow up with you. So we'll first dive into, there were several questions about the fiat screening, and can you use that for adolescents? And if not, what other screeners would you recommend for the adolescent population or the younger population?
That is a good question. The ones that I pulled from are, I believe, all adult. Some of them may go as young as 12, but none of them are going to be for the child population. Some of them do have child and adult versions. So if you were to look up any of the ones that I put on there, if that does exist, you would see that come up with it. But probably 50% of the ones that I put on there go as young as like 12 or 13. So I did not put any like specific kiddo or adolescent ones on here just because this was geared more towards the adult population, but that's a really good question. Some of them definitely go as young as 12.
Thank you so much. There were other questions around using DBT as an intervention. And in a private practice, is it okay to use DBT on an individual basis, or should people be looking more at comprehensive programs, or what could be the benefits of each of those?
So, that's a good question too. I mean, DBT, it's going to depend. It's going to depend on the specific presentation of the client. Some patients really benefit from more of that like DBT group-based curriculum where they can learn from others in that setting. Others benefit more from that one-to-one skill building piece. Like I know here at Rogers, the way we apply DBT in our informed state is on kind of a one-to-one, really focusing in on that skill building piece and that skill application. But we also have had people who really benefit from that group-based piece. I think it's going to be more about where they're struggling. So let's say the person is struggling more interpersonally with relationships, communication, feedback, things like that. Maybe that group atmosphere or that type of a DBT program might be more helpful for them. If it's really impairing their functioning there and they're really struggling with relationships kind of in multiple different areas of life, whereas maybe somebody could benefit individually if that wasn't going to be the focus. Dr. A, any thoughts on that?
I agree with you. And I think it's really based on the struggles and what that patient is presenting with at that moment.
Yeah, thank you. There were a couple of questions on, as a practitioner or provider, how do you relay to somebody that they have a borderline personality disorder, and what does that process look like, and what's the best approach to really deliver that information and support the client through that?
So, I mean, I know there's kind of a couple schools of thought on this. My thought on it is, if for me, the diagnosis, it's helpful for me to know from a case formulation approach. Like I just kind of know what I'm dealing with and how I'm functioning from that perspective. There's some patients that really kind of want to know what's going on, so they can just put like a diagnosis with their symptoms. There's some patients that get particularly escalated when they're told specific diagnoses, particularly when they're in that personality realm. So from my perspective, even if I know that, I've done my questionnaires and I know that, it's more about, I don't know that I need to tell them that that's what's going on, unless that's the type of patient who would receive that well, and that would help build insight and help strengthen the therapeutic relationship. If not, I'm going to focus more on symptoms. So here are the categories that you're struggling, and here's what I can do to help. And if they come to it on their own conclusion, I could say, yeah, I mean, those symptoms are most often associated with that. But what we need to focus on is how those symptoms are impacting your functioning. And that's why the fiat is really helpful, because it goes through those different categories and patients rate that themselves. They go through and circle the answers themselves. So they're saying that they struggle versus we're saying that they have this. I think that's just a really nice way to help start that dialogue if it is something that needs to happen. Or if not, it's a nice way to have a list of things that they struggle with and what we're going to focus on and how we can work with it. Dr. A, anything from your perspective as the provider?
Yeah. And I think it's always important to be open to not being sure, right? Like sometimes we meet the patients for the first time and it seems like, oh my God, this is it. But sometimes it's not really the case, right? So I would say allow yourself time to get to know that person first. A lot of the times when the mood symptoms are so strong, it can be as well the depression symptoms that are so in your face. And sometimes, like we saw during the presentation, a lot of the symptoms are coming, it's very similar in both ends, right? So sometimes if you allow yourself time to treat the symptoms that is in front of you, later on you'll be like, maybe not. If you only go with those eyes, that's all you're going to see, and you're not going to allow yourself to see anything else outside of it, right? Of course, it's always important to have working diagnosis on the back of your mind, and as you get to know that person, you're always going to know too how to introduce that idea, right? And if you feel that that's going to be more detrimental, because unfortunately there is a lot of stigma still, especially around personality pathologies here. So if you feel that that's going to be more detrimental to that person to learn about it initially, you don't have to go there. So maybe try to explore more of the symptoms and indirectly bring up the main ones and see if they identify with that. There are some people, like Dr. McCullars said, that they want a name. They want to know what's going on. And a lot of the times I will pull up the DSM-5 and say, let's go over the criteria here. What do you think? And a lot of them is like, oh my God, I really identify with 1, 2, 3, 4, and it's easier for them. And they have a name now, they know what to work on. So I think going slow and being open is always the best way to go.
Thank you. That's very helpful. Another theme that really popped up throughout was borderline personality disorder symptoms and then also trauma. So if you have a patient who has experienced trauma or traumatic events or ongoing trauma throughout their life, how do you differentiate between the two, and how do you separate, and are there different interventions that you would utilize? Or at what point would something be more complex trauma versus borderline personality disorder?
Woo, that could be a whole nother talk. Maybe that should be a whole other talk. So that is definitely another co-occurrence that happens for individuals who also are diagnosed with BPD. The intersectionality of that and the treatment of that is going to look different, obviously, than BPD when it comes to mood disorders and when it comes to MDD. What I would say, it still stands that you need to even do a more thorough assessment and screening, and really understand what that presentation is before diving into treatment. It's gonna require a lot of that on the front end. And it's going to depend on the nature of the trauma. Has this been long-standing psychological trauma? Mom was very verbally aggressive in the household, or is this multiple sexual assaults, right? That's really very much going to guide what type of treatment they may need. And then how they're going to respond to that type of treatment, given if they are diagnosed with borderline personality. That's the best answer I can give without that being like a full talk.
Yeah, and we see that come together a lot, right? Because if you stop to think, and if you really stop to work with a client that has borderline personality disorder for long enough, and you go back to explore their upbringing or their past, we're always going to encounter some type of traumatic event, right? Will those traumatic events always result in PTSD? Not always, right? But the traumatic events are most of the times present there. So I think it's, again, a matter of exploring how the symptoms are presenting themselves and affecting their lives, right? And how to best target that at that moment, because it can also be dynamic. It can be one thing here, and once they learn more skills, it can be presenting differently, and you can offer a different type of treatment later on. So I think it's more of what is happening here now, and how are you dealing with those symptoms here now? How can I better help that patient?
Mm-hmm. Thank you. Maybe that's the next webinar topic here in the future is the intersection of trauma and BPD. Thank you. Multiple questions around the age of diagnosis around BPD, and what age are we looking at, and how would you official diagnosis, a client is age 16. Thoughts on that? Is there a primary age that we should be diagnosing?
Dr. A, you want to take that one?
I'm not sure if there is a specific age cutoff, and please correct me if I'm wrong here, Dr. McCullars. I do think we have to always keep in mind that your brain requires time to fully develop, right? So keep that in mind, that as patients age, it's likely that with, especially the frontal lobe being better developed, the judgment piece of things will also improve. And you see that with BPD, right? The symptoms tend to get better as they age with time. So I would take in consideration the age, but also it's around that teenage, early adulthood years that we see more of the struggles of BPD, and that when the interventions could be most beneficial there.
Yeah, agreed. Not a specific age, more like a range. Late adolescent, early adulthood is when you see symptoms start to emerge that may be jumping into the category of like, okay, this could be more of a formal diagnosis. Whereas like, let's say someone comes in at age 16, is experiencing some of that emotional lability, having some self-harming or suicidal ideation. You have to take that developmental piece into account, because a 16-year-old female who is experiencing a lot of things at school or at home may be reacting in that way, or maybe expressing symptoms like that because of situational factors. But then she turns 18, 20, 22, and those don't really reemerge, or they continue. And it's more of this like stable, pervasive pattern that you're starting to see across different contexts. So.
And that leads into the next question on the other side. Can somebody really go into remission with the BPD, or the aging out piece? Like, is there a time that you would kind of tuck that away, or is it something that is going to be pervasive throughout someone's life?
Well, personality in itself is across the course of the lifetime, but I think with any other mental health disorder, I mean, I don't know that anything really goes into remission. It's more that it is well managed, and you're able to apply skills in the context where you need to act differently than maybe what the personality disorder or the mood disorder or anxiety disorder is telling you to do in that moment. So instead of like reacting, you're acting skillfully now, whereas like before you weren't. And so I would say the BPD symptoms do start to decrease in their intensity as the person ages. And I think somebody who has well-managed BPD, that would also help with that, you know, if it's somebody who's also been in treatment for that, for BPD in the past.
Okay.
But it's definitely something you have to keep applying those skills really regularly, keep practicing. I mean, just like with anything else when it comes to mental health.
Thank you. One question is the stress needed in order to be diagnosed with a personality disorder?
Is this, do you say the stress?
Is distress, yeah, like somebody being in distress, is that a requirement for a personality disorder diagnosis?
No, not like being in distress, like in the current moment, or just in general.
I'm not sure. I would say potentially in that person's life, is there distress happening that is potentially because of some of the symptomology that they're displaying or patterns of behaviors?
So I would say like distress in itself, no, but you have to see disruption in multiple contexts in their life. So disruption and impact of functioning when it comes to those different components that go into the diagnostic criteria.
Thank you. Several questions around Dr. A, the gut health element. And are there any supplements that you would recommend, or that there's research about to help enhance that? Or if you could speak more on that topic, folks are really interested.
Sure, of course. That's something that I am very interested on too as well. And there are plenty of studies showing lots of nutrients for mental health, the important role of microbiome in controlling mental health. As you may imagine, we're talking about trillions of bacteria out there, right? Like we're primarily made of bacteria, and different ones have different roles. One thing that is important to always remember is that, like I was saying, we don't have a big stock of things. Things are produced on a daily basis, right? So it's almost like we have to be working on that on a daily basis. Not like you're going to do something now and your gut's going to be great, or it's something that you have to be mindful of on a daily basis, right? What you're choosing to eat, how much water you're drinking, if you're being active, if you're making good choices. There are plenty of nutrients that are essential in the production of neurotransmitters, some B vitamins, vitamin D, which is actually a hormone, probiotics, exercise and good health. So there are different approaches that you can be utilizing on your practice, especially when you're thinking about behavior changes that could be of help even with the production of neurotransmitter and even with optimizing the effects of medication.
Thank you. We had several questions around supporting patients who are neurodivergent, and they also have a borderline personality disorder diagnosis. And would the focus still be on BPD, and then help to support the executive functioning of the aspects of autism or ADHD? Really, overall, in your experience, what have you found regarding the overlaps between BPD and autism?
I don't know that we've seen that a lot here, but I would still stand by what are the areas that they are struggling in? What is going on? I mean, there are a few similarities when it comes to like interpersonal relationships with those who are neurodivergent and BPD, having difficulty connecting, maintaining relationships, things like that. Obviously it's going to look a little bit differently with somebody with BPD versus somebody who has autism, but there's similar threads between a lot of the interpersonal aspects and maybe even some of the emotional expression pieces too. So again, I would still lean into, regardless of the diagnoses, what is going on, where is the person struggling, what are the behaviors that the individual is engaging in that are causing distress or that are causing a negative impact to their functioning, and what can we do, what skills do we need to apply. Now, if the individual is neurodivergent, you may have to pivot a little bit in the way that that skill is relayed or the way that you pose that skill to the patient, because the black and white thinking may be a little bit stronger in those individuals as compared to somebody who just has that BPD diagnosis. A little bit more of that rigidity that you may have to smooth out in the way that you relay skills, and also how the skills are practiced, and really ensuring that when a skill is practiced, if it is working and helping, you may have to do a little bit more process. It's like, well, why do you think that worked? Like, let's talk through that. Like, how was this different than how you've acted before? With individuals who are on the autism spectrum. That's what I would say.
Just adding to that, I think it's exactly that's more important than calling a name of the pathology and targeting the pathology in itself as what are the struggles of this person in front of me. And even after you identify the struggles, let's say in the case that Dr. McCullars just brought up, for example, the interpersonal difficulties. Okay, but what are difficulties for this person? Is it because they find themselves being socially awkward but they really want that? Is it because they are afraid of being judged? So what are the fears there? How can we help that person tolerate that fear better, and how to translate that message in a way that it's well understood?
Thank you. This may be essentially the same answer, so you could absolutely say everything we just said, Genevieve. But for individuals with BPD and potentially an eating disorder or substance use disorder, would you recommend DBT, or would you focus on stabilizing the substance use and the eating disorder aspect first?
Okay, substance and ED. Both can be very risky from a health standpoint. So I think you have to see where the person is at with regards to that. I mean, if this is somebody who has an eating disorder and has been restricting for like 5 years and is significantly underweight and is very, very far away from their ideal body weight and may have some medical complications, maybe their electrolytes are all out of whack and you're risking seizures or any other medical complications, you're going to need to definitely focus on like the physical health and safety of the patient before anything else. Same thing with substance use. If they're engaging in like repeated risky behaviors, if they're using a lot, if they're using regardless of the consequences, I mean, that person may need to detox first before then starting effective treatment. If you don't have the biological concerns or like the risky behaviors, then I think, I mean, people who use substances, we know that they use because there's something else going on underneath, depression, anxiety, personality, trauma, eating disorder. I mean, something that they're using the substance to cope with. So yes, you do want to focus on the reduction of their use. And also you want to function on the problematic behaviors that they're doing and why they're doing them to help them better understand how the substance use plays into that whole cycle. And then ED is kind of a whole another ball game, but similar. I mean, eating disorders are often caused because of an underlying anxiety disorder that's just tied to body weight, shape, and size. So kind of everything we've just said is just with those two in particular, there can be biological health and safety things that are going on that could be particularly dangerous that you need to make sure those are definitely managed first before you even have a shot at effective treatment.
Yeah, I completely agree with that. Like anorexia nervosa, for example, is the pathology with the highest risk of mortality in psychiatry, right? So if it's so acute, we have to like full focus on that. The same way as substance use, if it's acutely affecting somebody's life, you have to stabilize that first in a way before we start introducing other things. But let's say those are all in a more stable plan right now. Like Dr. McCullars just mentioned, they are using substances or like eating out of to treat or to mask some kind of distress they're on, right? So if you're asking them to remove those behaviors without giving them something else to use, coping skills or like using more DBT there to understand and help them cope with them, it's very unlikely that they're just gonna stop it, right? Unless you help them with something else. So it's again, seeing how acute the other pathologies are and where the patient is in terms of wanting to change, readiness for change.
Yeah, absolutely. Makes sense. Thank you. Can you speak to the other gender differences for BPD, specifically non-binary individuals, transgender individuals, and men?
Well, what we do know is that the rates between men and women are very similar, which was different than what was previously researched. And based on my knowledge and what I was able to come across in the literature, I did not see a lot about other identities that may be out there. I'm sure that research is happening and is occurring, but that is not something that I came across, so I can't really speak to it. Yeah, sorry, that could also be another talk.
We did have another question about TMS. Let me get back to that. So would you recommend TMS for an individual who has major depressive disorder and potentially a lot of allergies to medications? Would that be an intervention that could be utilized instead?
For sure. TMS has been approved for MDD since 2008. It's effective. The side effects of it and the risks of it are very little. Unfortunately, with insurances, we have to have failed trials, but if some people will even like be willing to do TMS even without trials of medications. That could be also something to consider depending on how likely they are to get side effects or allergies and so on and so forth, like you mentioned.
Mm-hmm. Thank you. Another question that came up is around supporting clinicians in doing this work. And so in my past experience with clients with a BP diagnosis, I felt very volatile and at times frightening, unpredictable, and exhausting. What can clinical supervision do when supporting clinicians in this challenge or in this work?
I think if there's an opportunity for that practice or whatever situation this might be, if there's ever a group supervision that can be held to where multiple clinicians can be in the same room and just not feel alone or not feel by themselves in this difficult, challenging work, I think that can be really helpful and effective if that's something that you're able to find or if the practice that you're in offers that. Just to be able to share like what's going on from your perspective and also that universality, like you're not alone. Yes, these cases are hard, but you're getting through it. And so is your colleague. And we're all here to talk about some of the struggle points and pain points. And then I think something that we forget to do a lot with challenging cases we tend to focus on what's going wrong or what's not going right, or what can we do differently or better. And I think sometimes we forget to praise ourselves for the positive things that have happened. Our client has come back for 5 sessions, and session 1, we were really unsure if they would even come back for session 2. We forget about those pieces, and we really get focused on how we can help her fix, and not the things that we may have already been doing, small little things that have led that patient on a nice path so far. So just making sure that we're pointing out the positives, not just with our colleagues, but also with ourselves if we don't have a group supervision, and just really participating in self-care, like making sure that when you go home and you leave work, and you go home and you focus on yourself and you do what fills up your cup. So that way the next day you're able to be your best self for the patients.
Thank you so much. And that is all the time we have today for questions. So thank you so much, Dr. McCullars and Dr. A, and everyone joining us on the call. Remember, if we did not get to your question or you have additional questions, you can email us at webinars@rogersbh.org. We will also have a recording of this program live on our YouTube channel within the coming days for you to review. Before we conclude, I'd like to ask our presenters if you have any additional resources that you could share with us before we conclude today.
Yeah, absolutely. So we put together this list of 4 different internet resources that were really helpful, provide a lot of different information, not only on treatment, but symptomology, and just different resources, not only for clinicians, but also for our patients. So different books they can read to help develop insight or provide them with psychoeducation, things like that. So I just listed them here.
Thank you so much. And that about wraps it up, everyone. Thank you so much for joining us today. I want to remind our participants that within the next 30 minutes, you'll receive an email with your link to your personal dashboard at ce-go.com. You will be able to view the slides as well as additional resources there. For those of you who met the required time requirements today for your CE, you will complete your evaluation at that time, and you can also download your CE certificate. If you have any additional questions, please send us a follow-up email at ce-go.com, and that would be about receiving the slides or your CE certificate for today. And again, thank you so much for joining us. Our community relations team would love to connect with you about your practice and how we can support your clients and your patients moving forward. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Have a good afternoon, everyone.